Assalamu alaikum. Hi, dear student in the fourth stage. Hope you're fine and in good health. And this is the fourth lecture about diabetes mellitus and the final lecture of diabetes in the field of endocrinology. Uh, as you remember, in the previous lectures, the first and the second and third, we talked about diabetes mellitus in different type, classification of disease, the pathophysiology of type 1, type 2 diabetes, and other different rare types of diabetes. And also we talked about the management of disease, how to investigate and to diagnose disease, how to look for and diagnose and manage the chronic and acute complications of disease. And this separate lecture presents the final lecture about diabetes mellitus, in which to talk is possible. We'll talk about specifically about the diabetes disorders in pregnancy. And the important thing in this lecture, because diabetes disorder in pregnancy represent a great and important challenges for the treating doctor and for you later on, because you are going to deal with two human beings, both to looking for the fetal health, and also we have to look for the maternal and the mother health, because the diabetes related disorder pregnancy have a negative impact for both the mother and the baby and the fetus. In a matter of definition and prevalence, actually, gestational diabetes mellitus is defined as diabetes with first onset or recognition during pregnancy. And the gestational diabetes, when we're going to talk about it generally, represents 17% of all pregnancies. And so diabetes will be diagnosed, or diabetes related to pregnancy as in a form of major definition gestational diabetes will be diagnosed and presented in 17% of a pregnancy. But important thing also, this definition include that patients who develop type 1 diabetes during pregnancy for the first time also, where a prompt action and early insulin treatment will be required, and also some patients who develop type 2 diabetes or had known pre-existing type 2 diabetes in whom diabetes does not remit after pregnancy. However, most cases actually gestational diabetes develop due to the inability of the body or the pancreas to secrete enough insulin to cope or to counteract the greater increase in the insulin resistance due to effect of the pregnancy-related hormone, specifically the human placental lactogens. And so gestational diabetes mellitus represent 88% of all diabetes-related disorder pregnancy, and a small majority, 12%, present pre-existing diabetes, whether type 1 or type 2 diabetes. How diabetes or gestational diabetes develop during pregnancy? The important factor actually the insulin resistance that occurs in normal pregnancy, and particularly in the second half of pregnancy. And for this reasons, the screenings and usually gestational diabetes develop in the second half of pregnancy. And gestational diabetes develop when the pancreas is unable to secrete sufficient insulin to compensate for the insulin resistance. So normally, in every pregnancy, there will be an increase in insulin resistance due to the effect of the pregnancy-related hormones. But when the pancreas is unable to secrete enough insulin, diabetes will develop later on. But for viewpoint about the physiology of insulin secretion in pregnancy, that giving that in early pregnancy, in which the time of enhanced insulin sensitivity actually at lower glucose level, and many women actually with a pre-existing type 1 diabetes or type 2 diabetes have lower insulin requirement and increased risk for hypoglycemia in the early and first few weeks, for example the first 2 weeks of a pregnancy. But later on, this situation will be rapidly reversed due to progressive increase in the degree of insulin resistance to plateau the insulin requirement. And later on in the second half of pregnancy, especially after the 20th weeks of pregnancy, later on the insulin requirement will be 2 to 3 times that of the pre-pregnancy level. So for this reason, patients with pre-existing diabetes, whether type 1 or type 2, they'll be increasing the insulin requirement. While in the absence of diabetes, gestational diabetes mellitus develop in the second half of pregnancy, because at this time there will be the highest level of insulin resistance. But important thing to note that not every woman develops gestational diabetes. As I said previously, gestational diabetes or diabetes presented in 17% of all pregnancies. Why not all patients or not all women develop gestational diabetes? Who are at risk for development of gestational diabetes in the second half of pregnancies? So there are risk factors that make this woman liable for development of gestational diabetes in the second half of pregnancy, and these are overweight or obesity, as defined as body mass index equal or more than 25, and age more than 25 years or equal to 25 years, ethnicity, certain ethnic group like Arab are from ethnic point of view more likely to develop gestational diabetes. Women with family history, special importance from family history of type 2 diabetes, previous glucose abnormalities during pregnancies, like example, previous gestational diabetes during pregnancy make the woman liable for the gestational diabetes in the second pregnancies. Previous macrosomic baby, and this the previous macrosomic baby indicate the presence of previous gestational diabetes or a higher degree of insulin resistance that's responsible for the development of macrosomic baby. Polyhydramnios, and also finally previous unexplained stillbirth. These risk factors, or these factors actually presented in women, indicate that this woman more likely to develop gestational diabetes in the current pregnancy and in the following pregnancies. And for these reasons, and due to the presence of these risk factors, those women should be screened maybe even at an earlier stage in their pregnancy, not in the second half of pregnancy. Why management of diabetes in general, whether pre-existing diabetes, whether type 1 or type 2 diabetes, or whether gestational diabetes, is important? Because diabetes during pregnancy increases the risk of adverse outcome for the woman itself. For example, there is adverse outcome affecting the pregnancy by itself, resulting in increased risk for development of gestational hypertension, polyhydramnios, and of course this increased risk for preterm labor. And for the labor itself, at the end of pregnancy, there will be a high rate for short dystocia due to the increasing the weight of the fetus, and the operative vaginal delivery, third of a degree perineal tear. There will be a high rate for cesarean section and also postpartum hemorrhage. And later in the life, those women with gestational diabetes, they are at risk for development of type 2 diabetes later on. Also, actually, in the same time, women with pre-existing diabetes, whether type 2 diabetes or type 1 diabetes, during pregnancy more likely to develop complications or certain complications during pregnancy. And for example, that women with type 1 diabetes, they are at high risk for development of diabetic ketoacidosis. There will be a high rate of hypoglycemia, especially in the first few weeks of pregnancy, worsening retinopathy during pregnancy, and also worsening of any existing chronic complications like chronic kidney disease, heart disease, or nerve problem. And pregnancy itself have a bad outcome and a bad effect on the diabetes of the woman during pregnancy. Beside the bad and worse negative impact of diabetes on the mother, diabetes during pregnancy have a negative impact and adverse outcome affecting the infants and the fetus. Due to unrecognized diabetes, there will be a high rate for stillbirth, congenital malformation, miscarriage, and perinatal death. Fetal developmental abnormalities like macrosomia and larger for gestational age, and this macrosomia make the fetus liable for birth trauma during and after birth due to shoulder dystocia, bone fractures, brachial plexus palsy, hyperbilirubinemia, and neonatal hypoglycemia due to hyperinsulinemia in the fetus, from the hyperinsulinemia of mother due to high rate of insulin resistance. Now I'm going to talk about screening and diagnosis of gestational diabetes mellitus. If you remember the way by which we used to screen diabetes mellitus, especially type 2 diabetes, we can diagnose and we can do screening even with a simple random blood glucose measurement, especially in the presence of symptoms, a fasting blood glucose, and HbA1c. The diagnosis and screening of gestational diabetes is different from type 2 diabetes in a way that we cannot use the HbA1c as a screening test for gestational diabetes, and the actual and the gold standard diagnostic test for diagnosis of gestational diabetes, which will be done in the second half, is the 75-gram oral glucose tolerance test with a plasma glucose measurement in the fasting and at 1 and 2 hours, and this testing should be done at the 24 and 28 weeks of gestation in women not previously diagnosed with overt diabetes. The oral glucose tolerance test is usually done the morning after an overnight fast of at least 8 hours. What is the criteria for gestational diabetes mellitus diagnosis? And gestational diabetes mellitus diagnosed when any of the following is achieved: if fasting plasma glucose equal or more than 92 mg per deciliter after 1 hour, or 75 oral glucose tolerance test if it is exceeding or equal to 180 mg per deciliter, and finally if the 2-hour plasma glucose equal or more than 153 mg per deciliter. If you look to these numbers, fasting blood glucose of more than 92, 1 hour more than 180, and 2 hour 153, these numbers are actually far away and lower than the real numbers by which we use as a cutoff for diagnosis of type 2 diabetes, because here we are dealing with a different type of diabetes, with gestational diabetes, and these cutoffs actually represent the level of blood glucose above which there will be a higher rate for the previously mentioned complications that can affect the fetal outcome and maternal outcome during pregnancy and after pregnancy. How to manage gestational diabetes? The first and the most important step, like in type 2 diabetes, is the lifestyle intervention. But in type 2 diabetes, the first line treatment is the lifestyle intervention plus the monotherapy, usually the starting metformin. While gestational diabetes, lifestyle intervention can be effective in the management and controlling the hyperglycemia gestational diabetes without the need of the additional therapy, and this can be successful in nearly 85% of all gestational diabetes. And so dietary modifications, and this particularly by reducing the consumption of refined carbohydrate, moving to more complex carbohydrate like the whole grains, and using take more vegetables, and this approach actually highly efficacious in the vast majority, as I said. And another important thing is the use of way and behavioral changing in the eating, that's spreading meals, is avoiding using 3 big or major meals, instead using 3 small meals and 3 snacks in a way that will spread and distribute the food over at least 24 hours or 18 hours in a way that will prevent the excursion or the higher increase in the plasma glucose, especially the postprandial states. By doing that, we are going to control the preprandial and the postprandial hyperglycemia gestational diabetes in a way can reduce these complications that I previously mentioned to a considerable degree. If there is a failure, or if the lifestyle intervention and dietary modifications fail to control the hyperglycemia in this state, we can use an oral anti-diabetic medications, and here we can use either metformin or glypinclamide. These 2 drugs considered to be safe during pregnancy, And also the insulin therapy is often required, but usually the drug therapy usually rarely needed, only in 15% of all gestational diabetes mellitus. And so what we need to do by management of gestational diabetes is not only to implement the lifestyle intervention and all, but also we have to look for having a control readings, and our target by serial blood glucose monitoring, by glucometer checking, we need to have a preprandial blood glucose that is of 95 or less than 95 milligram per deciliter, and 1 hour postprandial glucose of 160, and 2 hour postprandial of 140. So all pregnant women should check their blood glucose before meal in the early mornings, 2 hour or 1 hour after meal, in order to have a targeted reading that is not exceeding these targets. So with lifestyle intervention, as I said previously, we can have these normal readings or these target reading in 95% of all gestational diabetes mellitus, while for those patients that exceeding these targets, we can start oral antidiabetic medications like metformin or glibenclamide, and also sometimes we may need to start insulin therapy. By the time of delivery, the story will not be ended. Gestational diabetes is diabetes related to pregnancy, but the story will not end or stop after delivery, because we need to follow up those patients who develop diabetes during pregnancy and gestational diabetes. The first reason is that due to 50% of those patients with gestational diabetes are at risk for development of type 2 diabetes in the sexing in the next 10 years after delivery. And for these reasons, there should be a surveillance and screening for type 2 diabetes in the similar universal way of screening of type 2 diabetes by HbA1c, fasting blood glucose, or random blood glucose. And this should be done annually, especially if the woman have body mass index of 25 kg over square meter, and actually this represents the vast or nearly almost all women who develop gestational diabetes. So all women with gestational diabetes should have annual screening to look for development of type 2 diabetes in the next years. And also at the same time, the similar test, which is the oral glucose tolerance test that previously used in the second half of pregnancy in order to diagnose gestational diabetes, should be repeated 3 to 6 months after delivery in a way that to exclude the persistence of diabetes after delivery, because as I said, this diabetes that is diagnosed during pregnancy may be gestational diabetes or already a pre-existing diabetes that is diagnosed during pregnancy, so to exclude the possibility of the persistence of the disease post-delivery. And so this is the end. Thank you for listening, and be free to leave any questions or any comments. Have a nice day.